Hi all, I am Tiffany Hall from the SABM Iron Corner Advisory Panel. I'm pleased to bring you this short video from our perioperative anemia management segment covering preoperative assessment and treatment. Anemia is very common in patients preparing for surgery, with studies showing rates anywhere from 11 to 76%, depending on the procedure. In orthopedic surgeries alone, about 35% of those patients present with a hemoglobin level below 13. And in colorectal surgery, that number can reach as high as 75%. So why is this so important? Because perioperative anemia is not benign. It's associated with increased morbidity and mortality, and the risks grow with the severity of anemia. Optimizing a patient's blood health, especially hemoglobin levels before surgery, can significantly improve outcomes. In fact, failure to optimize pre-surgical hemoglobin levels of patients 12 and older between 13 and 16 grams a deciliter may need to have their elective surgery postponed. This is particularly critical in patients with cardiovascular disease who face even greater risk from anemia compared to patients without. Interestingly, randomized clinical trials continue to support a restrictive transfusion strategy even for this population. So how do we manage this proactively? The answer is early identification and treatment. Ideally, every preoperative patient should be screened for anemia and micronutrient deficiency at least 6 to 8 weeks before surgery. That gives us time as clinicians, the time that we need to correct their deficiencies and optimize their hemoglobin. A comprehensive lab panel is essential to this. We start with a complete blood count to assess red blood cell indices and hemoglobin level. Then we move to iron studies, including ferritin, transferrin saturation, and iron levels. Keep in mind that inflammation can mask true iron deficiency, so we also check a C-reactive protein to adjust our interpretation. We also look at vitamin B12 and reticulocyte hemoglobin, renal and thyroid function. If B12 deficiency is suspected, a homocysteine and methylmalonic acid level may be needed for additional confirmation. So what formal guidance is available for diagnosis and management of preoperative anemia? An international consensus statement was published in 2023 on anemia management in surgical patients from Shander and et al. I was actually fortunate enough to be part of that group. This statement provides formal guidance on the diagnosis and management of preoperative anemia. There are also other SABM endorsed algorithms that can be utilized as a resource, and you can find the links to the publication and the algorithm examples in the written content of this topic on the Iron Corner. Now let's talk about iron therapy, which plays a critical role in correcting anemia. Intravenous iron is often the preferred option, particularly when surgery is imminent or when oral iron is poorly tolerated. In fact, it's fast, effective, and bypasses the absorption issues seen with the oral formulations. And intravenous iron therapy should be tailored based on the patient's iron status, surgery timing, and patient tolerance to maximize the benefit and reduce surgical risk. Now, oral iron, on the other hand, has low bioavailability and often causes gastrointestinal side effects. This still may be appropriate and can be considered for patients with iron deficiency without anemia and no contraindications, or whose surgery is scheduled 6 to 8 weeks after diagnosis of anemia, with daily 40 to 60 milligram dosing or alternate day 80 to 100 milligram dosing, and the patient can tolerate it. So in summary, perioperative anemia should never be overlooked, and early screening and tailored treatment, especially with iron replacement, have shown to improve hemoglobin levels and reduce the need for blood transfusion and improve patient outcomes. Following these guidelines, we can significantly enhance surgical outcomes and patient safety. Thank you.